Welcome to this step-by-step guide on the cerebellar examination, part of the Study Neuro lecture series. Today we'll cover how to systematically assess coordination, balance, speech, eye movements, and how to use these findings to localize lesions within the cerebellum. Be sure to follow us on YouTube at Study Neuro for more in-depth lectures, clinical insights, and updates in neuroscience. We'll start with a quick review of the cerebellum's functional anatomy, focusing on how different regions control limb coordination, posture, and eye movements. Next, we'll discuss the core principles of a cerebellar assessment, emphasizing a structured approach that compares both sides and integrates timing, rhythm, and smoothness. For limb coordination, we'll demonstrate key tests, including the finger-to-nose, rapid alternating movements, and heel-to-shin maneuvers. Then we'll examine gait and tandem walking to assess truncal stability and balance. We'll also cover speech evaluation, highlighting dysarthria and scanning speech, and the oculomotor exam, including saccades, smooth pursuits, and gaze-evoked nystagmus. Finally, we'll discuss tremor assessments, the rebound phenomenon, and evaluation of muscle tone and reflexes. By the end of this lecture, you'll understand cerebellar functional anatomy, be able to perform a systematic bedside examination, recognize key signs of dysfunction, and localize lesions within the cerebellum with confidence. The cerebellum plays a key role in fine-tuning movement. Rather than generating strength, it coordinates the timing, precision, and adaptability of motor activity, which is essential for balance, posture, and motor learning. When the cerebellum is affected, patients develop ataxia and incoordination, but importantly, without true weakness or sensory loss. This leads to characteristic findings such as inaccurate targeting of movements, intention tremor, slurred speech, and an unsteady gait. Because these features can overlap with motor, sensory, or vestibular disorders, a careful clinical examination is crucial for accurate localization. The cerebellum is functionally organized into distinct regions, and understanding these divisions helps us localize lesions during the clinical exam. The vestibulocerebellum, located in the flocculonodular lobe, is primarily responsible for balance and eye movements. When this region is affected, patients develop truncal instability, a wide-based unsteady gait, abnormal eye movements such as nystagmus, and impaired vestibulo-ocular reflexes, often accompanied by vertigo-like symptoms. The spinocerebellum includes the vermis and the intermediate zones and plays a central role in maintaining axial posture, gait, and limb control. Lesions of the vermis typically produce truncal and gait ataxia, while involvement of the intermediate zone leads to incoordination of the limbs, particularly affecting accurate targeting of movements. The cerebrocerebellum, which comprises the lateral hemispheres, is involved in planning and fine-tuning voluntary movement. Damage here results in classic limb ataxia, including dysmetria, intention tremor, difficulty with rapid alternating movements, and a characteristic scanning dysarthria. Importantly, cerebellar dysfunction alters motor coordination without causing true weakness or sensory loss. This reflects the cerebellum's extensive connections with the cerebral cortex, brainstem, and spinal cord, through which it modulates motor output rather than generating force itself. A cerebellar examination should always follow a structured and systematic approach. Assessment begins with observing posture and spontaneous movement, then progresses to tasks that challenge coordination during active movement. It is essential to examine both sides and directly compare performance, as cerebellar deficits are often subtle and asymmetric. A complete evaluation includes the limbs, gait and stance, speech, and eye movements, since involvement of different cerebellar regions produces distinct clinical signs. Using a consistent sequence from inspection and gait to speech, limb coordination, and finally ocular movements helps ensure no key findings are missed. Importantly, cerebellar dysfunction is characterized by impaired coordination rather than true weakness or sensory loss, a distinction that is central to accurate localization. The first step in a cerebellar examination is general inspection. Start by observing the patient's posture, spontaneous movements, gait, and speech, as this can reveal subtle signs of cerebellar dysfunction. Pay attention to the way they stand and walk. Cerebellar involvement often causes a wide-based stance, truncal instability, or rhythmic head and trunk movements known as titubation. Next, watch for tremor during purposeful movements. Intention tremor is a hallmark of cerebellar disease and should be distinguished from resting tremor, which suggests a different disorder. Listen carefully to the patient's speech. Cerebellar dysarthria often presents as staccato or scanning speech with irregularly spaced syllables and slow or slurred articulation. Finally, observe the limbs and trunk for asymmetry or incoordination during simple tasks, as these findings can help localize the lesion. The finger-to-nose test is a key part of the cerebellar exam, used to evaluate the accuracy, timing, and smoothness of goal-directed movements in the upper limbs. This test reflects how well the cerebellum controls distal coordination. The main abnormality we look for is dysmetria, often accompanied by an intention tremor that worsens as the hand approaches the target. To perform the test, ask the patient to alternately touch your finger and then their own nose. Move your finger to different positions and have the patient repeat the task at a steady pace, testing one limb at a time. Comparing both sides helps identify asymmetry. While observing, note the accuracy of finger placement, watch for overshooting or undershooting, assess the smoothness and rhythm of movement, and look for tremor that appears with movement. In a normal exam, movements are smooth, accurate, and symmetrical without tremor. Abnormal findings help localize pathology. Overshoot or undershoot typically points to an ipsilateral cerebellar hemisphere lesion, intention tremor reinforces the diagnosis, asymmetry may indicate focal pathology, and bilateral impairment suggests midline or diffuse cerebellar disease. Always begin testing slowly, then progress to normal speed. And remember that visual guidance does not correct cerebellar incoordination. Importantly, performance reflects cerebellar function, not cortical motor control. Rapid alternating movements are an essential part of the cerebellar exam. They assess the speed, rhythm, and regularity of quickly alternating hand or limb movements, giving insight into the cerebellum's role in timing and sequencing. The main abnormality we look for is dysdiadochokinesia, which is a disruption of smooth, coordinated alternating movements. To test this, ask the patient to rapidly pronate and supinate one hand on the other, on the thigh or in the air. Another option is to have them tap the palm and dorsum of one hand rapidly on a surface. Always demonstrate the movement first, test one limb at a time, and compare both sides for symmetry. When observing, focus on speed, rhythm, and smoothness, as well as the accuracy and completeness of the rotation. Watch for progressive slowing or breakdown with repetition, which can indicate cerebellar dysfunction. Normal movements should be fast, smooth, and symmetrical, with full rotation and no hesitation. Abnormal findings help localize the lesion. Slow, irregular, or clumsy movements point to an ipsilateral cerebellar hemisphere. Asymmetry suggests focal pathology, and bilateral impairment indicates midline or diffuse cerebellar disease. Remember, dysdiadochokinesia reflects a timing problem rather than weakness, and visual guidance cannot correct cerebellar deficits. The heel-to-shin test is a key component of the cerebellar exam used to assess the accuracy and smooth sequencing of lower limb movements. It evaluates how well the cerebellum coordinates the leg during goal-directed tasks. To perform the test, have the patient lie supine. Ask them to place the heel of one foot on the opposite knee and then slide it smoothly down the shin to the ankle. The movement should be repeated several times, testing one limb at a time and comparing both sides for symmetry. While observing, pay attention to how accurately the heel tracks down the shin, the smoothness and continuity of the movement, and whether there is any side-to-side wavering, overshoot, undershoot, or loss of contact. Intention tremor may also be apparent as the heel nears the ankle. In a normal exam, the heel lands precisely on the shin and slides straight and smoothly to the ankle, with symmetrical performance on both sides. Abnormal findings, such as irregular, wobbly movements or repeated misplacement, point to cerebellar hemisphere dysfunction. Asymmetry suggests focal pathology, while bilateral incoordination may indicate midline or diffuse cerebellar disease. The Gait examination is a crucial part of assessing cerebellar function, as it reflects how the cerebellum contributes to balance, posture, and coordinated locomotion. By carefully observing a patient's stance and walking, we can identify subtle deficits in axial and limb coordination. The primary abnormality we look for is ataxia, which arises from dysfunction in the cerebellar vermis, the flocculonodular lobe, or their vestibular connections responsible for stabilizing the trunk and maintaining postural control. To perform the exam safely, have the patient stand and walk unaided if possible, while you remain close to guard against falls. Observe their normal gait over several steps, and then ask them to turn, stop, restart, and attempt tandem walking, placing one foot directly in front of the other. While watching, note the width of the base, step length and rhythm, trunk stability, arm swing, and balance during turns and tandem gait. In a healthy individual, gait is narrow-based, smooth, and symmetrical, with stable posture and intact tandem walking. Abnormal findings help localize cerebellar pathology. A wide-based, staggering gait points to a vermal lesion. Significant truncal sway indicates vestibulocerebellar dysfunction. Impaired tandem gait with preserved strength suggests cerebellar ataxia, and asymmetry may reflect a focal cerebellar problem. The speech examination is a key part of assessing cerebellar function because it evaluates how well the cerebellum coordinates articulation, timing, and prosody. Abnormalities here often reflect cerebellar dysarthria, which arises from dysfunction of the lateral cerebellar hemispheres and their connections with cortical motor speech areas. Begin by observing spontaneous speech, listening carefully for fluency, rhythm, and clarity. Next, challenge the patient with sentences containing alternating consonants, such as Peter Piper picked a peck of pickled peppers, or She sells seashells by the seashore, which tests coordinated tongue and lip movements. Then, ask the patient to perform rapid syllable repetition, like pataka, to assess the timing and sequencing of articulators. Finally, evaluate sustained vowel phonation using sounds like ah as in father, e as in see, or o as in go to examine voice stability, pitch control, and smooth airflow. Compare performance across all tasks for clarity, symmetry, and rhythmic consistency. Normal speech should be fluent, smooth, and consistent even during rapid or complex tasks. Abnormalities include slow, scanning, or irregular speech, which suggests a cerebellar hemisphere lesion, or explosive syllables with variable pitch, indicative of cerebellar dysarthria. Importantly, slurred speech with weakness may point to a bulbar disorder, not cerebellar dysfunction. Cerebellar dysarthria may occur alongside limb ataxia, dysmetria, or nystagmus. Remember, these speech abnormalities reflect incoordination, not weakness, and prosody and rhythm are just as important as articulation for localizing the lesion. In some patients, speech signs may even appear before obvious limb or gait deficits. When we examine eye movements, we're really assessing how well the cerebellum fine-tunes gaze accuracy and stability. The cerebellum doesn't initiate eye movements, but it ensures they are precise, smooth, and well-controlled. Start by watching how the eyes move when the patient shifts their gaze quickly between two targets. In a healthy system, the eyes land cleanly on target. In cerebellar disease, the eyes often overshoot or undershoot, a finding that reflects impaired cerebellar calibration rather than muscle weakness. Next, ask the patient to follow a slowly moving target. Normal pursuit is smooth and continuous. When cerebellar control is impaired, the eyes can't maintain smooth tracking and instead jump in small corrective movements, giving pursuit a jerky appearance. Then, assess gaze holding by asking the patient to look to the side and keep their eyes there. If the cerebellum is not stabilizing gaze properly, the eyes drift back toward center and repeatedly correct, producing gaze-evoked nystagmus. This is especially characteristic of vestibular-cerebellar involvement. Finally, test the vestibulo-ocular reflex by gently moving the head while the patient keeps their eyes fixed on a target. The eyes should remain steady despite head motion. Failure to do so suggests impaired cerebellar modulation of vestibular input. Together, inaccurate saccades, disrupted pursuit, and gaze-evoked nystagmus point to cerebellar dysfunction, not primary ocular pathology. These signs are subtle, but they are powerful localizers when interpreted correctly. When we assess tremor, the goal is to determine whether the cerebellum is responsible or whether the tremor arises from another motor system, such as the basal ganglia. Cerebellar tremor is classically an intention tremor, meaning it becomes more pronounced during purposeful movement rather than at rest. Begin by observing the patient at rest, with their hands relaxed on their lap. A true cerebellar tremor is typically absent in this position, which helps distinguish it from Parkinsonian resting tremor. Next, ask the patient to hold their arms outstretched. This allows you to identify any postural tremor. While mild postural tremor can be physiologic, asymmetry or associated incoordination should raise suspicion for cerebellar involvement. The most important step is to observe the patient during a goal-directed task, such as reaching for your finger and then touching their own nose. In cerebellar disease, the tremor emerges or worsens as the limb approaches the target. This increasing amplitude reflects impaired cerebellar control of movement precision and timing. As you test, compare both sides carefully. Cerebellar tremor is usually ipsilateral to the lesion, and asymmetry provides valuable localization. Throughout the task, pay attention not only to the tremor itself, but also to the smoothness and accuracy of the movement. The rebound phenomenon, also known as the Stewart-Holmes test, evaluates the cerebellum's ability to rapidly stop a voluntary movement once resistance is suddenly removed. This function depends on intact cerebellar timing and feedback inhibition. To perform the test, the patient holds their arm outstretched while resisting gentle pressure from the examiner. When that resistance is abruptly released, a healthy cerebellum immediately checks the movement and prevents the limb from overshooting. In cerebellar dysfunction, this checking mechanism fails. Instead of stopping smoothly, the arm may overshoot, swing forward excessively, or show uncontrolled oscillations. This reflects impaired coordination rather than weakness. It's essential to compare both sides carefully, as rebound failure is typically ipsilateral to a cerebellar hemisphere lesion. Asymmetry provides strong localizing value. Importantly, this test helps distinguish cerebellar disease from pyramidal weakness. In corticospinal lesions, the patient may be weak but still able to halt the movement appropriately. Assessing muscle tone helps us understand how the cerebellum modulates motor output rather than generating force itself. In cerebellar disease, the typical abnormality is hypotonia, which reflects impaired facilitation of motor activity rather than true weakness. Initiate the examination with the patient fully relaxed and well supported. passively move each limb through its full range of motion, paying attention to the resistance you feel at different joints. Always compare the right and left sides and assess both proximal and distal muscle groups, as cerebellar hypotonia can be subtle and asymmetric. In cerebellar dysfunction, the limbs often feel unusually loose or floppy, with reduced resistance to passive movement. After you release the limb, it may return slowly to its resting position instead of stopping promptly. Reflex testing can provide additional support for cerebellar hypotonia. When you elicit a deep tendon reflex, particularly at the knee or biceps, the limb may continue to swing back and forth in a pendular fashion. This finding helps distinguish cerebellar hypotonia from pyramidal lesions, which typically produce increased tone and brisk reflexes. Clinically, it's important to remember that cerebellar hypotonia occurs without loss of strength. For this reason, tone assessment is most informative when interpreted alongside coordination tests and reflex examination. A careful cerebellar examination relies on a structured approach that evaluates posture, muscle tone, coordination, gait, speech, and eye movements as a single integrated system. Interpreting the findings is not about isolated signs, but about recognizing patterns that allow accurate localization. Limb incoordination with dysmetria and intention tremor points towards cerebellar hemisphere involvement. Predominant gait and truncal instability suggest vermian dysfunction, while imbalance with nystagmus and abnormal eye movements implicates the flocculonodular lobe. Always pay close attention to asymmetry because cerebellar signs localize to the same side as the lesion. Finally, while imaging and laboratory studies are valuable, they confirm what the clinical examination has already suggested. Skilled bedside assessment remains the cornerstone of cerebellar diagnosis. Thanks for watching. Don't forget to like, share, and subscribe to Study Neuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.